We are glad to welcome you to our first BVI webinar today. All the BVI team wish you and your family that we wish you are safe in this difficult COVID-19 situation. So BVI is therefore continuing to offer the best knowledge of our physical lens portfolio to get the best patient satisfaction. Regarding the patient satisfaction, one of the main factors to achieve best outcomes is certainly the lens, but linked with perfect patient selection, eye preparation, biometry, patient communication. So today we have the chance to welcome Dr. Mertens from Belgium, Medipolis, to present a great topics. Erik, as you know, Erik owns a huge expertise in premium lenses. And I'm still remember when I met him the last time before the COVID-19 in Antwerp, he told me all patients who come to my practice must leave with my practice with spectacle freedom. So in this way today, Dr. Mertens is presenting the patient journey in his practice to achieve visual outcomes. So the agenda is we are going to start with the presentation of Dr. Mertens. Then we will have a Q&A session of 20 minutes. So Dr. Mertens is going to answer your questions. And we will give you also some journey survey, during the presentation. So over to you, Dr. Mertens, and thank again for your support.
Well, thank you, Sebastian, for your kind introduction. And I would like to thank Physial and BVI for giving me the opportunity in these very peculiar circumstances all over the world. We cannot meet on conferences, so webinars are the mode of teaching nowadays. So they asked me to talk about the patient journey in my practice to achieve visual freedom. First of all, my financial disclosure: I'm a consultant for Physial and BVI. And Sebastian brought up a poll here. So Sebastian, do you want the attendees already to vote here? I think so. So please do this. What is the percentage of multifocal lens in your practice? Up to 10%, between 10 and 20%, 20 to 30% on more than 30%. And the second question is, what is your favorite premium lens choice in your practice? Trifocal, EDOF, extended depth of focus, or bifocal? You can vote now, so we can continue afterwards with the presentation. So I hope everyone has voted, so we can continue with the presentation. First of all, here are already the results. What is the percentage? About well, 58% up to 10%, and 18% between 10 and 20. And I think that Sebastian maybe will discuss this later on. So I'll continue with my presentation. Factors which are determinant for the results after surgery. And there are 4 of them. First of all is the selection of the patient, how to communicate with the patient, how to prepare the eye for surgery, and of course then the choice of the trifocal or multifocal IOL itself. Let's first talk about patient selection. It is of course extremely important to select the right patient. You have to look at the personality, you have to take gender into account, what activities is that patient doing during the week or the weekends, and of course what are their eyes look like. Let's first talk about personality. Well, we have to shy away from people who are perfectionists or aggressive and demanding personalities. And of course, easygoing people and people losing or wanting to lose their spectacles or not using their spectacles are very good candidates. And in gender, I must admit that women are better candidates than men, and aggressive men, alpha men, are poor candidates for this kind of surgery. Now, what about activities? People with high visual requirements are not good candidates, or people working at night or in dark places. And also astronomers, bird watchers, or photographers are not good candidates for multifocal. Of course, there are exceptions, but these are general rules I'm giving you. And that's why we ask these patients, of course, what their activities, what's their occupation, what sports do they do they wear contact lenses, do they wear glasses, how much time are they spending behind a desk using computers, driving at night, which gives you a very good insight in the daily activities of the patient, and the choice of the intraocular lens will be also determined by this. Sport people are very good candidates, party people, farmers and outdoor workers are very good candidates for this. What about the eyes itself? Please be sure that you only select eyes with correctable astigmatism. Irregular astigmatism, of course, will not give good results. Any patient who is totally dependent on spectacles is a good candidate. Hyperopes are, of course, much easier to please than myopes, because myopes up to -3, -3.5, they can read without glasses, of course, and they may lose some best correct near visual acuity after surgery. So these are, or you have to talk them through, of course. So in general, and usually, the worse the patients start, the happier they will end. So in summary, the best patient is a relaxed one, a friendly one, a hyperopic lady who does not do many visually challenging tasks and is totally dependent on her spectacles. Of course, that's the best. And the worst patient is that alpha male, that aggressive myopic alpha male with high visual requirements and short temper, who spends many hours reading without his glasses. So this is what the patient selection is about. And I think Sébastien will bring up a poll here also. I will ask you a few questions. So Sébastien, please.
Thank you, Erik. Regarding the first questions, we ask you after my introduction. So here in the audience, 58% of you are using multifocal lenses, around 0 or 10% of their patients. And what is your favorite premium lenses choice in your practice? And I'm glad to read it. The first choice is trifocal lenses, also the FineVision for sure. So regarding the patient selection, I'm going to just to ask you some questions. I'm going to send the survey. I hope you can see it.
Yeah,
so the first question is, do you suggest multifocal lenses to all your patients? And what are the most important criteria to choose a multifocal lens for you?
Please, you can vote now.
Yes.
How long do they have to vote, Sébastien, normally?
We can wait 15 seconds.
Yes, okay, good. Thank you.
We have time, so no problem.
Yes.
So, but we can see already a trend regarding the questions. So, do you suggest multifocal lenses to all your patients? 53% say no. So, only 15% of the audience are going to suggest multifocal lenses to all their patients. What are the most important criteria to choose a multifocal lens? So the first criteria seems to be the personality of the patient. The second is the work and hobbies. The third is lifestyle. Then is driving at night. After that, the age and the gender of the patient.
Yes, okay. Well, that's indeed, age and gender are, well, I told you that females are easier going than male in this regard, but it doesn't have to be that you exclude males, of course, and also the age doesn't matter, except for, of course, eyes with pathology. So we have to turn them down. Okay, thank you. And we continue with the rest of the presentations. So the second topic is patient communication, which is extremely, extremely important in this kind of surgery. Because remember, you as a doctor are responsible. You have to listen to your patient and to understand what he wants, what he needs, what his demands are. So this is, doctors are not, we are not used to do that. So take your time and listen to your patient and try to understand. Be friendly, smile, make the patient, your friends, make the patient at ease, and get the patient to smile. So try never to be arrogant, like I'm the doctor, I know what I'm doing, and you're just a patient and you have to listen to me. That doesn't work. And patients are not suing you for making a mistake. They're suing you because they don't like you. So this is a take-home message. Be careful when you when they do not like the doctor, they can sue. But when you make a mistake, just be honest and talk to the patient. They will never sue. So arrogance is not the way to go here. Another thing is share time. It's very important, preoperatively. It can be done by the doctor, the eye surgeon as well, or in my practice, I have 3 patient coordinators who do that, because it takes a lot of time. They spend 30 to 45 minutes with each patient to explain everything, which is extremely important. And you have to set realistic expectations. Explain also that it can take 3 to 6 months to neuroadapt, and also explain the different focal points. What are the side effects? Show the pictures, videos, animations, and of course, before doing surgery, get a signed informed consent where you tell them that they had the possibility to ask questions, that they read the brochure, that they understood it, that they knew the complications, and so on, so that there is no issue afterwards, because doctors are sued and get in court are getting in problems when the patient is not well informed and he cannot prove it. So bear that in mind. So actually, what we need to do is create trust. That's our job. We have to create trust to our patient, and the patient doesn't care what you know until he understands and feels that you care about him or her. And sometimes you have to see a patient a second time without extra charging him to explain everything again. So it reduces fear before doing surgery. And also bear in mind that the patient itself, they often do not listen. There are many publications out there who state that the patients only remember 10% of what the doctor says. And of that 10% of what you say, half of it is sometimes understood wrongly. So these are astronomical percentages. That's so little that the patient takes home in correct information. So when you overload the patient with information, he will misunderstand, and the more he also will forget. So keep it clear, keep it simple, and keep it to the point. So they do not often understand because they have, of course, a limited knowledge. We are trained many years in medicine and in ophthalmology. And that new information can be confusing. Not only explaining myopia, hyperopia, astigmatism, presbyopia, it will confuse them. They use these terms, they do not understand what it means. So show them what it means, explain them with figures and so on. And most patients just want to know that you know and that you are on top of things. Exceptions are, of course, engineers, and so they truly want to understand what's going on. What about expectations? People, of course, they expect when you do surgery that they return when they were 20 years old. They can see far up close without any side effects. Of course, that's not true. And the most difficult thing is to predict how the patient will react to the side effects of that multifocal lens. And well, this is said already many times, under promise and over deliver, and managing the expectations of the patients are extremely important in this regard. Before we go to the next topic, Sébastien will bring up another poll, I think.
Yes, Erik. So for the eye preparation, I'm going to send the survey now. I think you can vote now. Feel free. So we have 3 questions. The first is, do you check the tear film of the cornea before offering a multifocal lens? Second question, are post-LASIK patients a good candidate for FineVision? And the third one, are you afraid not to get the best post-op refraction with trifocal lens? I'm going to wait 30 seconds. It's okay for you, Erik?
Yes.
Because it's moving.
I'm not going anywhere. These are very important questions, Sebastian, and I will explain most of them in the rest of my talk. The one I'm not addressing in my talk is the post-LASIK patients, but I can address this during the Q&A session after the presentation.
Okay. I'm going to share. So the first question for the tear film. So 80% are checking the tear film of the cornea before offering multifocal lens. Second, so are post-LASIK patients a good candidates? 76% say no. And are you afraid not to get the best post-op refraction with trifocal lens? 70% say yes.
Okay. Good, thank you. So very interesting.
So I'm going to share the screen for you, with you.
Yeah, we're seeing the screen.
You can see it.
Yeah.
Perfect.
Very good. Thank you. So, well, the third topic is the eye preparation, which is extremely important to get very good results. So you already asked it during your poll. You have to optimize the ocular surface. You need to do a perfect biometry and aim for spherical equivalent between plus or minus half diopter. Measure the astigmatism accurately, not only the front curvature of the cornea, but also the posterior curvature of the cornea is very important, as we know. And plan the treatments such as what I do is when from 0.75 diopter astigmatism onwards, I'm using a toric implant for these cases. So first what we do is that we look at the cornea, we look at the anterior elevation and the posterior elevation of the cornea and the corneal thickness. And also what is extremely important, and this is the map of the CSO machine. And you see the epithelial thickness map. And this gives you a very, very, very good indication of the quality of that cornea. When the epithelial map is not uniformous, please take care of it first before relying on the biometry, because you will get not good results. We have very good instruments right now, like the IOL Master 700 and LensStar and so on. So I'm not going to in detail because we all know them as very reliable and good machines. Let's talk about the ocular surface first, because dry eye disease is everywhere. More than 25 million Europeans suffer from dry eye disease, and 3.2 billion euro are spent on dry eye symptom relief annually only in the European Union. And as we know, as ophthalmologists, this is the most frequently encountered disease in our practices. So to improve the outcomes after a refractive surgery or a lens exchange, you have to recognize the insufficiency of the tear film, and you have to treat it adequately. But how can we do it in a good way before going to surgery? So briefly, there are two primary forms. You have the MGD, the alveolar gland disease, the lipid deficiency, which is about 86%, and the aqueous deficiency, only 40%. And you have a lot of mixed forms and so on. But we can, for those interested, they can have a look at the DUCE-2 study, which was, I think, 1.5 years, 2 years ago, was released, and there you can see what they found out. What we do in our practice is we try to diagnose this subjectively, but also objectively. So we first start with a questionnaire. We have two good questionnaires, which is the OSDI, the Ocular Surface Disease Index questionnaire, or the SPEED questionnaire, and it will also give you the subjective feeling of the patient of their dry eyes. Then the anamnesis is, of course, very important, but two things are extremely important, because what we sometimes forget is that eye drops, like people who are on glaucoma medication, they take for a long time eye drops, and this will have a significant effect on the quality of the tear film. And also look for partial blinkers, because these are the dangerous ones, and afterwards you get bad results and you don't know what is happening. So look at the biomicroscope whether there are partial blinkers or not, and talk to the patient and explain what it does. We have a lot of diagnostic tests for us, and of course we cannot do them all preoperatively. It would take too much time to do them all. So most important tools are the non-invasive breakup time. And you have the Oculus, who is doing that, the TOMI, the CSO, Sirius Machine, and a bunch of others. So this is, I think, very important to understand yourself and to explain to the patient what the tear film looks like. Here you can see where the tear film is breaking up earlier, and this is a very normal, this is what we want to see, that the break up time is long. Another thing is, although there is a debate around, because the testing is not always stable, the measurements are not always stable, but when you have a good measurement, the osmolarity is low and stable, and it is about 290 milliosmoles per liter is the normal value. And dry eye subjects, they exhibit elevated and unstable osmolarity. And a hallmark of dry eye is actually difference between the two eyes of more than 8 milliosmoles per liter. And this was found as the least variable of all common signs. But bear in mind, measure the tear osmolarity before you do something else, before you even do the puff tonometry or do the subjective refraction, because this will alter the osmolarity. This is the first test you have to do, otherwise you will get unreliable results. There was a very nice paper of Alice Epitropoulos a couple of years ago in Journal of Cataract Refractive Surgery, who found that in the hyperosmolar group, there was a significant difference in IOL power calculation. So there is a lot to do about tear film quality. And when you see a bad tear film quality, first treat them. Treat them with steroids, with anti-inflammatory drugs without preservatives, of course, with lubricants without preservative, and let them come back in 3-4 weeks and repeat your measurements. And you will see that sometimes, this is one of examples of a patient of mine. You see here and the 43.33 diopters as mean, and 1 month later, it's almost 1 diopter difference. When the tear film stabilized, we got a 0.9 diopter difference, which resulted in a half a diopter, even more, of IOL power difference. And you can say, well, what does it matter? Because this is only one variable. The real positioning of the lens in the eye is a variable. The surgical technique is a variable. The IOL power, it's when you implant a 23 diopter lens, it's not always a 23 diopter, it can be 23.2 or 22.8. So the least variables you have, the better you will be to get to that endpoint between plus and minus half a diopter. So this is just one example, but I have many examples with 1.5 to 2 diopters of a difference in IOL power. And also in this case, the astigmatism was pretty stable, the axis is pretty stable, but I've seen lots of cases with 20-30 degrees axis shift when they came back 3-4 weeks after treatment of the dry eyes. So what we do in our practice is what I call the dry eye express. It saves time, it gives you very good, very good understanding of the quality of the tear film. So first, the questionnaire to give subjective feeling of the patient, measuring the tear osmolarity, the MMP9, and the Meibography. The Meibography is extremely important. Why is this extremely important? Because you can show the image of the patient. And when a patient has a loss of meibomian glands, it will appear here on the picture. And then they will understand, like, oh my God, there's something going on there. When you talk about non-invasive breakup time, they do not understand what it is. The breakup time, what is it, and what does it what does it do for the quality of my vision? But when you show them the loss of meibomian glands, it's like the loss of a body part. And the loss of a body part is shocking to a patient. Oh my God, did I lose already so many glands? And then they understand like there's something going on, even when they do not feel anything. And when you do not treat it, after 1 month after surgery, they will come back and they will not be happy. Another thing you can tell your patients is like the tear film works like the wipers of your car. When they're not, they have not a good quality anymore, and it rains, and you try to wipe the front window of your car, it will create stripes, and you will not have a good vision. So that is what your tear film does. It makes your window clear so you can have a good vision. So we need to take care of this before doing any surgery, or the patient will blame you that you did not do a good surgery. So pre-op testing and adequate treatment is key here, and I cannot stress this enough. And I found this publication in Current Eye Research in 2017 about the satisfaction after cataract surgery. And it was the dry eye symptoms which were more closely associated with patient postoperative satisfaction than the measurement of the visual acuity. So this is very important to bear in mind. And what is my take-home message? Test all patients preoperatively, not only the old ones, also the young ones, because most of them are wearing contact lenses, and it will have an impact on the quality of the tear film. Show them a meibomian gland picture, as I explained to you. The osmolarity is the least variable of all common signs. And when I started doing this, I always ask my patients 1 month after surgery, how satisfied are you? Between 1 to 5 out of 5. And 4 out of 5 or 5 out of 5 is what I call the good satisfaction rate. And it was before taking care of the tear film, 76%. And it went up to 93% when we took care of the tear film and made it good before doing surgery. So, and also my retreatment rate dropped from 11 to 3% when taking care of the tear film. So this is extremely important. Another thing I wanted to touch is the retina, the retinal consideration in refractive lens exchange and putting in a multifocal IOL. Of course, we all know the retina is very important, and you need to do a very good vitreoretinal examination. And you have to put this also, or I advise you to put it also into your informed consent. Because studies show that posterior vitreous detachment after cataract surgery and after refractive lens exchange are very common. And these two studies, they show incidences between 50 and 75% of PVD within 5 to 6 years after lens exchange, which is of course a huge number. And why is that important? Because when you treat younger patients, the younger patients, they have a firm vitreous, and when the PVD occurs, it's a violent process, and it can create a tear, especially in high myopes. The risk is about 2% of retinal detachment after surgery. So bear that in mind, and especially in young myopes with no PVD, these are the dangerous ones to create a retinal detachment. So do a very good macular and retinal examination. Do it pre-op, so you can also show the difference to patients eventually. And for you, of course, a very valuable tool. And look at this. There is still a vitreous attached at the fovea, and it's pulling here at the fovea. When you do not do an OCT, and best is to do an indirect ophthalmoscopy and prophylactic laser coagulation when you find superior round holes, of course, or horseshoe tears, of course, you have to treat always. So use the swept source OCT in every pre-op case. And like in this case, you can see there is already a posterior vitreous detachment. And assess the macula as well. This is a partial hole, so it's very important to see this as a surgeon and also to explain to a patient what is going on. Because you will certainly affect the vitreous, and you will certainly, in half of 3/4 of the cases, within 5 years, you will end up with a PVD and induce it earlier than expected. You have to educate your patient what it is, and that they have to contact you as soon as possible when the symptoms occur. And of course, consider referral to a vitreoretinal retinal surgeon when you're not sure about the retina. Intraoperatively, what to do? Of course, eliminate astigmatism and take care of your surgically induced astigmatism. You have to measure that for yourself and do 20-30 cases and measure the keratometry postoperatively and preoperatively, and what does it change by your incision, by your surgery, what it is, and you can take it into the future operations, into your calculation. Consider limbal relaxing incisions or acquired keratotomies if necessary, and from what I do is 3/4 of diopter astigmatism, I use a toric multifocal IOL. Make a perfect CCC. I do a fairly large one between 5.2 and 5.4 because studies have found that this is more stable and that is creating less possible tears during surgery. I use the capsule laser in some instances, or we use the Victus laser in Medipolis. Also, when you're planting the lens, avoid decentration or tilt. A decentration, well, these are just numbers, of course. Up to 4 microns, in my opinion, is acceptable. And tilt is very sensitive, so not more than 3 degrees tilt is advised in these cases. This is a small surgical video injection of the trifocal FineVision lens. So the first design. So here you see that's a fairly large rexis, and just take out all of the viscoelastic and center the lens nicely into the bag. Postoperatively, well, assume that you see PCO, you have to yak. But of course, you have to bear in mind, when you do a yak and the patient is not satisfied afterwards, and you need to take out the multifocal IOL, you're in trouble. So make sure that the patient wants to retain the multifocal IOL before you yak. Correct any residual refractive errors. You can do it with LASIK, PRK, with SMILE, with add-on lenses, what you prefer. And when you have to want or need to replace the multifocal IOL, do it as soon as possible. And of course, how long for that particular patient will the neuroadaptation take place? You never know. And this is a discussion in between the patient and yourself. And when is it too late? This is, I cannot answer that. Is very patient dependent. Again, before going to the next topic, I would like to ask Sébastien to bring up another poll.
Yes, thank you, Erik. So I think you can see the survey now. It's open. So there are 2 questions. One, are you used to do multifocal lens with mix and match? And what are the most important criteria to choose a multifocal IOL? So I'm waiting 1 minute, and it's okay for you, Erik, and we are going to share the answers. So I remember all the attendants that you can write any questions you would like to ask to Erik Mertens. So after the presentation, we will have a QR session. So please feel free to write any question you would like to ask to Erik. I've already received some. Okay, I'm going to share the answer. So, first question, are you used to do multifocal lenses mix and match? 70% say no. Okay, so some of you are doing still mix and match implantation. And what are the most important criteria to choose a multifocal lens? So 50-50 is the first to answer together the same level, the technology long-term follow-up and the safety of the lens. Third is the toric version available, very important, as Erik showed us. And then there is the lower risk of photic phenomena. Then the price, training supports, then the time to deliver the lens, and the last, the preloaded version available. Thank you. Any comments, Erik? If you want to make any comments, please feel free.
I will make the comments during the next. Okay. I can integrate that into my talk. Yeah, good.
Perfect.
Thank you, Sebastian. So, well, let's talk about the trifocal or the multifocal IOL itself. And first, some history. As you know, Physiol brought to market the first trifocal IOL in 2010 at the micro F design with the Mickey Mouse ears, which was followed 3 years later by the Pot F, and 1 year later by the Pot F, the toric version. These are all hydrophilic lenses. Then Physiol started with their hydrophobic line, premium trifocal lenses, in 2018, and last year they introduced the EDOF lens, the Triumph EDOF hydrophobic lens. Now, when you look at the timeline by specification, again at the micro F, the first trifocal lens ever in the world, it was hydrophilic, and the energy for the energy distribution was most for far than near and intermediate, which is the same for these other four, for the Pot F, for the Pot FT, and the hydrophobic. And last year, so the Triumph lens was introduced, and there is a difference because the energy distribution for intermediate was augmented and less energy distribution, light energy distribution for near. On top of that, there was an introduction of a longitudinal chromatic aberration correction to get less side effects, less glare and halos, and a better quality of vision. And on the mix and match question, what Sebastian pulled out in the poll is what I'm doing now, not most of the time, but in several cases, I like to put the Triumph one in the dominant eye to have a good distance vision and intermediate vision, and in a non-dominant eye, the FineVision, the classic FineVision hydrophobic one, to have an extra near vision. And the funny thing is that patients, they, even when they do the refractive salute, as we call it, they do not feel that there are two different types of lenses in their eye, and it gives you very good and very fast intermediate vision as well. So I'd like you to try it if you want, and in my hands it gives very good results. Here again, difference between the classic FineVision with the micro F and the Pot F design. This is the Pot F, and here the Triumph lens, which has a more intermediate energy distribution of the light. And as you can see here, what happened? It got away. Let me try it. Let me put it back up on. Okay, here it is. So we have some ridges here on the haptics, which gives you by implantation that they not stick together. The haptics do not stick together. This is actually why the ridges are there. So, in conclusion, what did we learn today? What I try to tell you is that patient selection, when you start, for instance, choose a hyperopic one, choose a lady which has no high visual demands to begin with. Listen to the patient, listen, and not, we're always trying to talk to patients and impose what we know. No, first listen, what are their expectations? Explain the side effects in an understandable way. Do not use very complex language. Optimize the eye, so take care of the tear film. When in doubt, treat the tear film and let them come back afterwards to do a biometry and the keratometry reading again. Do butterfly surgery, and of course the IOL selection that we discussed just a few minutes ago. Before ending, I would like to call your attention for the next webinar given by my good friend and excellent surgeon, Bobby Ang from Manila, from the Philippines. This will be on Thursday, 7th of May, starting 2 p.m. At Brussels time, so this is GMT +2.
Thank you.
Thank you.
You are perfect on time, so we have time for questions. I'm going to read the question we received now. First one is, what is your preferred A constants for FineVision?
They actually is 118.92 for. You have to, what you do, you put in 20 of the lenses and then you recalculate. There are Excel files for that, you put it in, and then the Excel file will calculate for you your A constant for my 118.92 with the IOL master. But it's individual, it can change from surgeon to surgeon.
Thank you. Are all patients more than 80 years good candidates for FineVision?
Well, the age is for me not an issue. Huh? You have patients 70 years old, which are very bad eye quality, tear film, retina, and so on. And others are 80, 85, 90 years old, and they have very good quality eyes. So age is not an issue. We look at the quality of the eye and we're not looking at the age of the patient.
Okay, next question. Great input, thank you. What did you do to treat the surface Preop drops or IPL?
Well, very good question. We all know that dry eye treatments treating dry eyes is not easy. We start with drops, so I use steroids. First, preservative-free steroids for 3 to 4 weeks. Then the patient comes back, and then when you have a stable tear film, we continue. But otherwise, when it's not enough, we can do IPL treatments for sure, and LipiFlow, all of that stuff, until we get a good stable tear film. So it's not a one solution for every patient. Okay.
Are you measuring the kappa angle or the alpha angle before implanting any multifocal lenses?
Yes, we measure it. We have the eye trace for that. But the funny thing is, I can't remember his name. He's a surgeon from the States, and he's the medical director from a chain in the UK, and he had 15,000 eyes, and he looked retrospectively what was the influence on the kappa angle on the post-op results, and everybody in the audience was surprised that even with large angle kappas, they were as satisfied as with low angle kappas. So I think we have to look at big data here, and our intuition is not always correct. When we looked at these numbers, the kappa angle doesn't seem to play a big role in the satisfaction of the patient post-operatively.
So you don't have any, I would say, maximum angle kappa to exclude a patient for FineVision?
Not really. What I'm looking at is in the IOL master, you have an image where you can see the tilt of the capsular bag. Mm-hmm. Sometimes you see extreme tilts in those capsular bags. I remember one patient, before I was looking at these images, she had no corneal astigmatism, no astigmatism at all. I put in the lens and I ended up with 1.5 diopter of astigmatism. I was like, come on, what's going on here? And then retrospectively, I looked at the IOL master and I saw that the capsular bag was really tilted in a horizontal way. And that was the solution of the problem. And then I treated her with PRK to get rid of the astigmatism. Of course, I needed to figure it out before surgery and not after surgery. But it took me a while to figure that problem out.
Okay, thank you. Have you tried monovision option?
Not that much. In Belgium, I tried it many years ago when I was doing a lot of LASIK and PRK. And most people in Belgium, they do not like that much monovision. And they want good vision for distance and for near. And in my practice, I don't like it.
Okay. What is your preferred method of calculating the astigmatism of the patient, biometry or topography?
Well, both actually. So the latest upgrade on the IOL Master 700, which is the True K. You have the True K, which is a very nice tool, which gives you actually and it takes into account the front part and the posterior part of the cornea. It's a very reliable tool. You can also have it on most topographers. They also measure the front and the posterior part of the cornea. So, and in 95% of cases, they match very good the True K on the IOL Master and on the topographer.
Is your Rexis size the same with femto as it was with manual capsule Rexis?
Well, no, with femto, I can go a little bit bigger because I know it will be a circular one, and I want actually an overlap of the anterior capsule 360 degrees on the IOL. With a manual Rexis, it's even when you do a very good job, it's not always easy to know where the center of your IOL will be once placed in the bag. So I tend to do a smaller one for when do manual. But since 6 years, I never do manual Rexis anymore for premium IOLs. I always do femto or capsule laser.
Okay, and it's linked with this question: what is the rate of decentration? Even you have a perfect Rexis in the back of the IOL implantation. So have you a rate decentration of lenses?
The thing is, with the femtosecond laser we use, the Rexis is centered on the apex of the anterior lens capsule. So sometimes it decenters and then you think like, oh, what's going on? But when you put the lens in the bag, that lens is centering very well in respect to the Rexis. So the top of the anterior capsule is actually very important to take into account. And that does the OCT on your femtosecond laser.
Are you checking higher order aberration before deciding to implant trifocal lens?
Well, the cornea, the corneal higher order aberrations are taken into account. But a lot of them are or irregular astigmatism, or it comes from a bad tear film. So, and after treatment of a tear film, as I already discussed, we measure it again.
What is your IOL formula, your favorite IOL formula?
Well, I use the Hill, which is available online for free, and also the Barrett. The Barrett. These are the tools, in my opinion, are most reliable formulas today. Again,
high order aberration. There are so many questions about it. Have you a maximum high order aberration of the cornea that you take in account to implant a lens or a trifocal lens?
I don't like cut-off numbers because like in the old days when we were performing LASIK at 250 microns of stromal bed, we had to leave it. It's enough. Where does that number come from? What actually I do is with the eye trace, we can simulate what will be the visual quality of that eye after implantation of the trifocal. And that is actually my guidance. The image the eye trace is giving me is my guidance for deciding to implant a multifocal trifocal IOL or not.
Okay. Can you use a FineVision in the dominant eye and a monofocal in the other eye to retain her myopia? Second eye is not good candidate given the high angle kappa.
Can you repeat the question, Sebastian? So
can you use a FineVision in a dominant eye and a monofocal in the other eye to retain her myopia? To be honest, I don't really.
I don't think that's a good idea because you have the three focal points in the dominant eye, and of course the brain picks the image of the dominant eye and makes it, well, that's what they rely on. And And when you get another image from the other eye, it will try to not take that image into account. So I would not do that.
How the epithelium map can be helpful in FineVision treatment?
Yes, yes. So before doing surgery, I always look at the epithelial thickness map. And when you have their irregularities, you have to treat it first. Otherwise, patients will be very unhappy.
They are only required a constant keratometry, or do you need other measurements? I think so. No.
Because I do not
understand. Wait, the US surgeon who studied kappa angle was Steve Scalorn. The name?
Schellhorn, yes, exactly. Schellhorn, yes, exactly. Yeah. That was the guy, exactly. So he presented 2 years ago, I think, at the ACOS meeting in the States. And it was very impressive numbers. And he was also very surprised.
Do you use CTR for premium lenses?
I used to use it, and I stopped because I did not see a difference in outcomes. The only thing, well, it's an extra manipulation in the eye. It's an extra cost, of course. The only thing where it is helpful, when you have to do an explant, in those rare cases, you have to do an explantation of an IOL, then it's much easier to get that lens out of the bag. But since a couple of years, I do not use the CTR on a regular basis, unless we have singular problems. I do not use it anymore.
What is the profile of patient that you fear the most with multifocal lenses or FineVision?
Yeah. Well, well, as I discussed, it are alpha males, the people who are trying to get on top of things. And sometimes they can persuade you to go for surgery, and afterwards they're unhappy. Although you discussed it, they still are unhappy. And I said, yeah, I thought it would be different with me. These are the most difficult ones. Okay,
we have a long question from Dr. Sanchez-Leon. When do you suggest to combine EDOF-Fizzle dominant eye and micro-F for non-dominant?
Yes, well, people who are working a lot on screens on a computer, I put in both eyes a triumph lens. But you have people who are like accountants who have to read up-close numbers on a paper and on the screen. These are the ideal candidates to put in a triumph in the dominant eye and the FineVision trifocal in a non-dominant eye. So they can read up close the numbers and they can see their computer screen very well.
What is your experience with triumph both eyes?
Well, I started more than a year ago, I think, with triumph in both eyes. And what surprised me is that although it's an EDOF lens and although there is less light going to the near focus, that they're still able to see very well up close. They need more light. That is it's normal because the light distribution is less for near. So when you do that, stress this, that patients need a lot more light for reading up close.
Which are your limits for any Fizzle multifocal lenses in hyperops? The hyperops are, of course, very difficult. The high hyperops, you have to take into account your axial length. Below 18 millimeters of axial length, this becomes also the predictability is much less. I will do eye per eye if I go for it. And on the other hand, you see sometimes what I already explained is on the IOL master, the tilt of the capsular bag, and you have a lot of tilt there. You will induce astigmatism, refractive astigmatism in these kinds of eyes, so don't do it. Any comments about Fizzle multifocal lens in post-op refractive surgery?
Oh yeah, That was the question I wanted to answer during my presentation, but I forgot. Well, I have a lot of experience with trifocal IOLs, post-refractive surgery, even post-RK, post-LASIK, post-PRK. We do a couple of patients each month, so for 5-6 years now. And the trick is there has to be the central 3 millimeters of the cornea needs to be stable astigmatism, or not, how must I say? So it has to be a very stable zone in the center. So not a lot of different dioptric powers in the 3 millimeter central zone. And these patients are, because they already had refractive surgery and they're demanding for surgery, and they want to get rid of their reading glasses. Only thing is, post-refractive surgery, most of them have dry eyes. Post-RK, tell them it will take a long time because they will end up first 4, 5, 6 weeks in hyperopia, so they cannot read, or they cannot read well in the beginning. It will take time for the post-RK patients to settle down, and the cornea will get stable in between 4 weeks and 3 months.
Professor Haller, just a question from him. How do you measure the tilt of IOL? You mentioned 3 degrees are acceptable.
Yeah, also with the eye trace, you can measure it there. You can measure the tilt of the IOL implanted.
Why is FineVision your first choice? There are so many competitors, many competition in lenses.
Well, I used a lot of the other lenses, and I always come back to FineVision. I tested all of them actually, and still FineVision is giving me the best. Maybe I have because I have a lot of experience with these lenses, that it gives me the best results. But in my hands, that's the way it is.
Any experience with pilots, patients, or kids? You have any experience with FineVision?
With kids, no. With pilots, well, the problem with pilots is when you do an implant of a multifocal IOL, then they will be grounded. So be careful to make sure that that you know what their profession is. Putting in a multifocal IOL, and then the pilot will get grounded. He or she will not be happy, and they will sue you for that.
What type of FineVision would you suggest to implant in an ophthalmologist patient? Would you mix and match them or not?
Oh, I have to think about that. I don't know. When looking through a microscope, it doesn't make a difference. And I don't see any. I need to think about it a little bit longer, but on first sight, I do not see any problems by not doing it.
Okay. What injector do you prefer, and what is your incision size?
I use just the injector which is provided by Physio, and my injections is 2.2 millimeters. Any
idea about the touch-up rate after FineVision implantation?
Yeah, it is 3%. So it was 11 because of, I mentioned it in my presentation, 11% before taking care of the tear film quality, and it dropped to 3% afterwards.
If ever you have a cataract surgery on your eye, which IOL will you prefer?
Well, I think I would go for the Triumph. It's, actually, I implanted my future wife about almost in June. It's a year ago, and she has very good night vision, and she does a lot of work on the computer. She's very happy with it.
Perfect. The last one, the last question, because it's 3. What is your personal feeling regarding the rebound in flow of refractive patients after the COVID-19 period, due to the fear, economical argument, etc.?
Well, that's a very good question, and I thought that it would take time to get back to the numbers before COVID. But actually, from what I hear from my colleagues from Asia, Southeast Asia, actually refractive surgery, the numbers were to 80–90% back up from pre-COVID, pretty soon after they reopened, and the cataract surgery numbers were lower than the pre-COVID. So we will opening up in a couple of days, May 4th, we'll start to do consultation again. So we'll see, but I was very surprised to hear that in Asia, that the refractive surgery market was back up sooner than the cataract surgery market. So we'll see.
Perfect, thank you. So we are perfectly on time. I would like to thank you again, Dr. Mertens. That was really wonderful presentation.
Thank you.
And I think it was quite interactive also with the surgeons. We were more than 270 during this webinar. So thank you very much. So as Erik told you, we are going to have next week another webinar with Dr. Ang from Philippines regarding the FineVision technologies, more deeply in the FineVision technologies. So I hope to see you there, and take care everybody, stay at home, and thank you very much to participate to this first webinar. Thank you very much, Erik. Thank you everybody.